Welcome back to Mastering Medical, part 4 of our renal rapid review. Here is the single most useful sentence in this entire topic. Serum sodium is not a sodium problem, it is a water problem. Sodium concentration tells you how much water is sitting with the salt, which is why volume status matters so much and why the same low sodium can mean 4 completely different diseases. In this video, we build one sequence you can run every time, then attach the diuretics that move all of it. Let's start. First, the two mirror image disorders of antidiuretic hormone. A patient with a lung malignancy has low sodium, low serum osmolality, and concentrated urine. The rule here is that neither the serum nor the urine means anything alone. Pair them. What do they say together? In the syndrome of inappropriate antidiuretic hormone, there is too much hormone effect, so the kidney holds on to free water it should be dumping. Serum sodium falls, serum osmolality falls, and the urine is inappropriately concentrated, with urine osmolality above 100 and urine sodium above 40 in a euvolemic patient. Classic causes are small cell lung cancer, central nervous system disease, pulmonary disease, and drugs like carbamazepine and selective serotonin reuptake inhibitors. Management is fluid restriction, treating the cause, and tolvaptan when needed. In diabetes insipidus, the hormone effect is missing, so free water pours out. Urine is dilute and high volume. Serum osmolality rises and sodium climbs, especially when the patient cannot drink to keep up, which is why the elderly and the intubated get into trouble fastest. So the discipline for any sodium disorder is to pair serum sodium with urine osmolality, then add urine sodium. Never name the disorder of one value. Now split diabetes insipidus itself. A patient on lithium stays polyuric with dilute urine even after desmopressin. This is the cleanest test in all of renal physiology because it asks a single mechanical question. Give the hormone. Does the kidney respond? Central diabetes insipidus is a supply problem. The hypothalamus or posterior pituitary is not releasing enough antidiuretic hormone from trauma, surgery, a tumor, or infiltrative disease. The kidney is perfectly healthy and simply has nothing to respond to. Nephrogenic diabetes insipidus is a response problem. Hormone is present, but the collecting duct cannot act on it. The causes you must know are lithium, hypercalcemia, hypokalemia, and inherited defects in the receptor or the water channel. The water deprivation test sorts them. Deprive the patient of water, and in both cases the urine stays inappropriately dilute because neither can concentrate on their own. Then give desmopressin. In central disease, urine osmolality jumps, usually by more than 50%, because you just supplied the missing hormone. In nephrogenic disease, almost nothing happens because the kidney was never able to listen. Supply versus response decided by one injection. Now let's build the full hyponatremia algorithm because this is the highest yield sequence in the whole topic. A cirrhotic patient has ascites, edema, and low sodium. Before you do anything else, one look at the patient answers most of it. Are they dry, normal, or swollen? Run the same 4 steps every time. Step 1. Prove the hyponatremia is truly hypotonic by checking serum osmolality, because hyperglycemia and severe hyperlipidemia produce pseudo-hyponatremia and you do not want to treat a lab artifact. Step 2. Check urine osmolality. Under 100 means the kidney is appropriately dumping water, so think primary polydipsia or beer potomania. Above 100 means antidiuretic hormone is active, and now you keep going. Step 3. Examine volume status because that is what names the disease. Step 4. Use urine sodium to refine it. In hypovolemic hyponatremia, the patient is dry with orthostasis and tachycardia, and the hormone is appropriate for the low volume. Urine sodium under 20 means extra renal losses like vomiting or diarrhea, while urine sodium above 20 points to renal losses like diuretics or adrenal insufficiency. In euvolemic hyponatremia, there is no edema and no depletion. Urine osmolality is above 100 and urine sodium is above 40. That is the syndrome of inappropriate antidiuretic hormone. In hypervolemic hyponatremia, the patient is visibly overloaded with edema, ascites, or raised jugular venous pressure from heart failure, cirrhosis, nephrotic syndrome, or kidney failure. The paradox worth understanding is that they are drowning in total body water while the effective arterial volume is low, which is exactly why the hormone stays switched on. Last pair, and it is the payoff for everything above. A patient in pulmonary edema gets furosemide and later has tinnitus, low potassium, and a metabolic alkalosis. Diuretics become easy the moment you stop memorizing side effects and start locating the drug on the nephron. So, where does it act, and then what happens to calcium? Loop diuretics, furosemide and bumetanide, block the sodium-potassium 2-chloride transporter in the thick ascending limb. That is the most powerful site available because it also collapses the medullary concentration gradient. The consequences follow logically: massive diuresis, a hypokalemic metabolic alkalosis, and calcium wasted into the urine, which is why loops are used in hypercalcemia. Add ototoxicity as the signature toxicity. Thiazides act further down in the distal convoluted tubule on the sodium chloride cotransporter. Weaker diuresis, still hypokalemic and still an alkalosis, but the calcium goes the other way. Thiazides retain calcium, which is why they help calcium stones and why they can unmask hypercalcemia. Thiazides are also the classic drug cause of hyponatremia. Potassium-sparing drugs act last in the collecting duct. Amiloride and triamterene block the epithelial sodium channel directly, while spironolactone and eplerenone block the aldosterone receptor. Weak diuretics, but they raise potassium instead of lowering it, and spironolactone adds antiandrogen effects like gynecomastia. So locate the site first, then attach potassium, calcium, and the signature toxicity. The rest is derivable. Let's lock it in. Low sodium with concentrated urine is the syndrome of inappropriate antidiuretic hormone, while high sodium with dilute urine is diabetes insipidus. Within diabetes insipidus, if desmopressin concentrates the urine, it is central, and if nothing happens, it is nephrogenic. So think lithium, high calcium, or low potassium. And for any hyponatremia, run the same 4 steps: serum osmolality, then urine osmolality, then volume status, then urine sodium. The volume exam is what names the disease. Dry is hypovolemic. Normal is the syndrome of inappropriate antidiuretic hormone, and swollen is hypervolemic. For diuretics, loops lose calcium, thiazides keep calcium, and potassium-sparing agents raise potassium. And the habit to carry out of this video: serum sodium is a water problem, not a salt problem. That is part 4. Part 5 takes on potassium and acid base, including the renal tubular acidoses and the one that comes with high potassium instead of low. See you there.